Good morning and welcome from all around the world to Structural Heart Live Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Fuster Heart Hospital in New York City. My name is Pedro Moreno. I will be your moderator today. We want to hear from you, so please send us all your questions directly from the website or from YouTube. And remember, all our cases, including this one, will be available at our website, www.ccclivecases.org. Today, we have a very excellent case, and we're going to do a slight modification. Dr. Sharma is going to start giving his talk, and then we'll move on into the case. Go ahead, Dr. Sharma.
Good morning. We always try to show more difficult cases. I mean, knowing that the structural field is evolving very rapidly, and people want to see more complex cases, and this is actually the e-blast which we sent is very particular about that this patient has a two TAVR valve. First embolized, then put a second valve. During that time, patient has a big cardiovascular collapse, requires CPR, but did fine, but then has a vascular complication, has a bilateral surgical cut down and repair. And so there is like extensive peripheral disease, and then these two valves. So we felt that this will be very atypical. I mean, for us also, we have done now close to 4,000 TAVR. This will be the first valve of its kind to do. So we'll show it. It will be a little delay because it requires surgical cut down, and our surgical colleague, Dr. Justin George, is working with the rest of the team, with myself, Dr. Keeney, Dr. Gilbert Tang, Sahil Khera, and our fellows and the rest of the staff. So we will come to the actual case maybe after 10-15 minutes, give them time uninterrupted so we get our vascular access, but we can present the case meanwhile. These are our the faculty involved with anesthesia. Anesthesiologist is Dr. Joseph Larisi. So this is a redo TAVR with a 26mm SAPIEN-3 Ultra Resilia valve in a failed embolized Evolut FX valve with a severe PVL. So this patient is 84 year. This is our episode 58. Patient which has been in trouble since 2023, has a severe aortic stenosis, had a valve, the bypass surgery in 1994, and at that time, which was last year in November, had a severe AS being treated outside. The first valve embolized, has a dissection, complete heart block, then patient has a peripheral vascular disease that time, has a stents and bypass, and also has a known carotid disease. So this case, in terms of alternate access, is very limited because of the peripheral disease, and carotid was not appropriate. And then, of course, in good medical therapy, when the cath done was in November, we didn't repeat now because there were 4 patent grafts. But then patient had a echo which showed moderate to severe PVL with a multiple jets, very little gradient. So it's all is the Evolut FX valve where causing the significant PVL. If we take, I think we can show the active echo, maybe what this is, which we had, showing the significant PVL, and we'll come back to the active, the echo at present. Now, CT, you want to talk about CT?
Yeah, let me do. Oh, you were talking about case. Sure. Hi, good morning, everybody. Welcome. This is an extremely difficult case, and we'll show you why in a moment. So now we are standardizing our approach to evaluate TAV-in-TAV or redo TAVR, particularly with self-expanding valve Evolut, which is a lot more complex than, let's say, failed SAPIEN. So in this case, you can see how we calculate is go from the inflow, and we calculate node 1, node 2 will illustrate the case on fluoroscopy, all the way up to node 6 where the commissures are, and we measure the dimensions. And you can see that here is the valve is underexpanded because the waist of a 29 Evolut should be 23. And you can see that this is slightly under that. But more importantly, in this case, the mechanism of failure is perivalvular leak, not the valve degeneration. So you need to size it appropriately to reduce the PVL, not for the failure. Next slide. And you can see that here the sinuses are big, the valve was implanted, a little bit deep. You can see the right screen that there are two valves in the body. The first one embolized and had to be retrieved, and then the second one was implanted roughly at the right position. But the root is big enough to accommodate a second valve without coronary obstruction. That is the key. Next slide.
That's the key. Coronary obstruction is, otherwise would have been a trouble.
So this is the app that Vinny Bapat and his group has developed that will be coming out very soon in terms of launch. Next slide. And this is kind of workflow that you can basically use on your phone or on the website. People put in all the numbers that we previously worked up, and they will be able to recommend a valve position based on coronary obstruction risk and potentially even the combination. Next slide. So this is all illustration purpose. We're not going to have time to go into this detail, but you can see that the options are you implant a high and no 6 where the commissures are, but that's not going to solve the PVL problem. So in this case, you do implant a little bit deeper and then expect the inflow of the SAPIEN-3 to anchor and seal against the inflow of the Evolut to reduce the leak, because that's what we're here for. Next slide.
Yeah. So in this case, rather than going up, we want to go a little down.
Yeah, not too down because we don't want the valve to embolize, but you can certainly make sure. You can see that here we do the numbers, and you can see we still size based on the manufacturer recommendation. Next slide. And so based on that, you can see that the coronary obstruction risk is low, as I mentioned before. So it tells you all this information when you put into this app. Next slide. And then finally, you can see these are the two options of positioning. And we think that probably no 5, roughly there, will be the target. But remember, when you inflate a valve inside a valve, you can move. You can move up or you can move down. So we actually like to start a little bit higher and let it come down a little bit. And there's been some discussion about when you put a SAPIEN-3 inside a TAVR valve, it falls short on both sides. So with SAPIEN-3, we typically say, well, it falls short from the bottom up, but not with TAV-in-TAV. It actually may fall short in both ways. So you have to perhaps account for that as well.
Okay.
Stay there.
Yeah. Beautiful.
So you can see that how the arch, so people ask, well, can we do carotid access here because all this issue? The answer is no. You can see that arrow there, the bend in the nominal artery, that is really not suitable. And also the left carotid, you can see the turn to the aortic annulus. Yep. So the SAPIEN system, even with the command, it'll be very difficult to make that turn to load the valve. You cannot really hard to load the valve inside an existing Evolut valve. So we usually like to use a Certitude valve because it's pre-mounted. So because of that, I think it's important that we have to try femoral first.
Yep.
Give me some dry gauze.
And so therefore, in summary, so this is the high-risk patient, super high risk actually, and unusual case, which I mean, we know a lot of live cases, but I don't think anybody has seen this kind of case, 2 valve already, and now trying to go third one. Initially, we thought that it will be percutaneous, but clearly has a bigger issue. And now with a surgical cut down and on top of it, further dilatation and the stenting, they will tell you exactly what it is, and we'll give them few more minutes to get ready before we come to. So meanwhile, they ask me that let's go to our didactic discussion of the 5 points I want to talk about today, and then we'll come back to in next 5-10 minutes, they should be ready. So what I'm going to do is, one is the redo tower versus native tower, 1-year outcomes. The Lighten trial of the balloon expandable versus self-expanding in the small surgical aortic prosthesis. Then 5th generation balloon expandable valve tower in USA, which is the SAPIEN-3 Ultra Resilia. They call it S3UR. Then the Corevalve expanded use, TAV-in-TAV, 5-year follow-up. And then lastly, the new innovative treatment is the ultrasound, non-invasive ultrasound therapy for severe AS, particularly those who are non-surgical. So first is the redo tower registry. This is the data presented originally, and then in the Europe, in the European Society, and then published in Lancet from the TVT registry by Raj Makkar. So what they did is took the matched patients, redo tower, whether self-expanding or balloon expandable, and versus native tower, and they're matched on various characteristics shown on the right side, 1-to-1, and about 2,400 patients, and basically showed that yes, the redo tower have slightly higher complication, but non-statistical. You see that numbers are there, of the brown bar, higher than the white, but minor, not major difference. Let's say need for second valve, it's 0.5% versus 0. Coronary obstruction is 0.3 versus 0, so very small. Need for conversion to open heart surgery, 0.4 to 0.2%. So very, very small difference, but non-significant. More important, we want to know the in-hospital and 30-day outcome. As you can see here, redo TAVR and the native TAVR, adjusted, identical outcome at 30 days. But 30 days is not enough. We need to know 1 year. And these are the data at 1 year. You see that every endpoint, death, stroke, valve intervention, life-threatening bleeding, pacemaker, new onset AFib was identical between two groups, or any readmission. So all of them are similar between two groups. So only difference was the redo TAVR has a higher residual gradient, as you can see, and the mean, of course the mean gradient and the mean valve area. You can see there is slightly lower with the redo TAVR versus native TAVR. So slight difference, very small hemodynamic difference, but at 1 year, no difference. At 5-10 year, we need to see later on. So then, just to emphasize on this point quickly, will show you two separate data. And data basically is that if you have a TAVR degeneration, then what do you do now? So these cases which I showed, everybody got a redo TAVR. So but if you have a redo surgical valve replacement, that you have a surgical valve, and now question is, do you do a TAVR or SAVR? So most important point we have learned that once you have a TAVR and you do a SAVR, very high mortality, 17%, compared to patient has a degenerated valve and went for surgery, will be a 17 versus 9%. Other endpoints are also shown, all are against the TAVR explant and doing a surgical valve replacement. So therefore, what I say basically is that if you have decided the TAVR procedure, make sure that that is the procedure for that patient. And because once you start talking about the TAVR explant, and this is a study by Gilbert Tang with the multi-center data showing that continue to be redo TAVR versus TAVR explant. Of course, redo TAVR you do cases which are appropriate, not every case, but overall it seems to be that the mortality is double or triple compared to redo TAVR versus SAVR, but clearly these are the selected cases. And of course, the TAVR degeneration, what is the cause for the repeat procedure? It's usually which determine whether patient go for TAVR explant. Most important is valve issue, patient prosthetic mismatch. Those are the cases will go for surgical explant, but those associated with higher mortality, and whether it's a surgical, which is self-expanding or balloon expandable, does not make a difference. So point with these two data is that anytime when we are talking about the TAVR in the life cycle of a patient with aortic stenosis, it has to be that is the final treatment for this case, because if we are thinking that maybe TAVR now and then do the surgery, that's not a good approach, because that is associated with higher mortality in every study so far. And maybe I'll ask Gilbert to comment on that, because we lead author that what basically the message besides that we learn that of course even a matched patients, that many times those patients go for redo TAVR redo TAVR versus surgical valve replacement and explant is still remain a high mortality.
Yeah, no, I think the two lessons learned about TAVR explant, even though the surgeons are getting better. Number one, the average volume per surgeon is very low. So we don't see that very often in the community. Number two, actually almost half the patient require concomitant surgeries. It's not just isolated AVR. So I think that is the difference between that versus redo TAVR, which is just a valve problem. So I think it's a different kind of patient population. But ideally, as Dr. Sharma mentioned, that if you can redo TAVR, and we've done probably the most live cases actually in the world featuring this subject, that it can be done very safely, but you need a lot of planning. And I think from an outcome standpoint, definitely, if the patient can avoid surgery, I would recommend it unless it's absolutely not possible.
And apparently, Dr. Ron Waxman is planning a trial for these redo patients, comparing with the redo versus surgical explant. But I know if they both are comparable, nobody will go for explant.
I think the interesting point is that if you talk about younger patients, right? These are younger patients, because if you're 80-year-old, you're not going to do TAVR explant, or even 75-year-old, they turn 80. These are younger patients, let's say 60-something. Most of them come to our clinic because they don't want surgery, because they have to go to work, they have to feed their kids. There are other extraneous reasons. They're low risk for avoiding surgery. So I think in my mind as a surgeon, to try to convince a patient, now you have a failed TAVR, let's go for surgery now. It's very hard to get the patient to agree to it if they already don't want surgery the first time, and we have to tell them that TAVR explant will be higher risk than first-time surgery.
Absolutely, very good point. Great point. So therefore, now then there is another trial which was presented earlier in European Society, and now we have 1 year data. We have shown that about in our earlier the live cases that now we have the 1 year data of the Lighten trial. The Lighten trial is in a small surgical aortic prosthesis less than 23 millimeters, randomize them to Evolut or the balloon expandable SAPIEN. And this was done in Canada, US, and Europe. And this small number of cases, basically about 100 patients. And then we have a 1 year data. And you can see here what we learned. The blue versus brown. So blue is your balloon expandable and brown is self-expanding. So basically self-expanding gives you lower gradient and better aortic valve orifice. That's one. As you can see and then only thing is the valve performance, which we call the fulfilled more often criteria of the intended performance of the valve, which is better with the self-expanding valve compared to balloon expandable. And that basically is that what is the residual gradient and how much is the PVL and so. So overall, it seems to be that hemodynamic point of view that the self-expanding valve does better compared to balloon expandable. In the 71 patients, 33 got balloon expandable, 38 got the self-expanding. Now, as far as the other endpoints, which basically is the heart classification, then KCCQ, absolutely no difference in two valve types. And these are the 1 year outcome. And 1 year outcome again, you see that identical, no difference. So yes, the self-expanding has the advantage of a better hemodynamics, but did not translate into a better clinical outcome at 1 year. Now, could it do it better later on, after 3 or 5 years, because hemodynamics were better? We do not know. And of course, we'll continue to have publication on this field. So this basically is the Lighten trial, as you can see here. The most important being the valve performance based on the gradient was less than 20, peak velocity was less than 3, and the Doppler velocity of index of more than 0.25 and less than moderate aortic regurgitation. So that's a valve performance. And that valve performance was better with a self-expanding versus balloon expandable, but without any outcome difference at 1 year.
Give me the wire.
So this basically is the outcome, then we have the 5th generation SAPIEN-3 Ultra Resilia. So every valve continues to go through various changes happening in every field, whether SAPIEN, the Corevalve, the Evolut, and so forth. And of course, even with the Accurate Neo and of course Navitor. So all these keep changing. So this is the basically SAPIEN-3 Ultra Resilia, which is called as a S3 5th generation UR. Represent the latest iteration of the valve technology, utilizes bovine pericardial leaflet tissue designed to reduce structural valve deterioration via calcification, as well as the addition of an improved outer sealing skirt to the 29mm valve. And sizes were designed to optimize hemodynamic performance. So basically, it's a better valve. And question is, does it show better hemodynamics? And answer there is, they compared from the TVT registry, 10,000 patient Ultra Resilia versus S3 and Ultra. And overall, you can see the valve orifice, effective orifice is better with the Resilia 2.1 versus 1.9. So corresponding mean gradient was lower, 8 versus 11. So seems to be a less paravalvular leak. You can see that mild to moderate, which was 0.5% became 5.8%. So clearly less paravalvular leak, better valve hemodynamics in terms of effective orifice area, and lower mean gradient with the new S3UR.
Where's the wire?
And this looks very good, and therefore at the discharge also the same thing. This Resilia Ultra valve did a better hemodynamic performance in terms of, as I mentioned in the points earlier. So now, only question comes, it looks good, lower PVL, all, but does it translate into a better outcome? Well, we don't have that yet. 6 months or 1 year, those outcomes are not available yet, but I'm sure soon will be available, and it's likely that it will translate into the better clinical outcome, but we do not have that at present. So then the fourth point was the 5-year follow-up of the Corevalve expanded use TAVR in failed surgical aortic valve. and basically showed that at 5 years, whether original your degeneration was stenosis, regurgitation, or combined, clearly stenosis has slightly lower outcome or bad outcome compared to others in terms of mortality, but overall not much difference. But just to say that overall it's dependent on patient prosthetic mismatch. If you have a severe PPM, outcome is almost 1.5 times, 38% versus 51%. So clearly it has to be that valve hemodynamics have to be optimized when we are using TAV-in-TAV as shown here. Of course, the other endpoints are shown here, which are predictors. Now, as far as what also we learned, that whatever the valve area you achieved, at time 0, it remains good for 5 years. So that's the key. Paravalvular regurgitation actually decreases, but more importantly, whatever you achieved at time of discharge, it kind of remains constant at follow-up, and more clearly, patient do quite well.
Much better, yeah.
Then the other question which I said, last one was the severe symptomatic AS using non-invasive ultrasound therapy in the patient particularly where you could not do the surgery, and this proof of concept that high beam energy ultrasound from outside, non-invasive, can it calcify? There are a lot of first in vitro data, then animal data, that it does cause decalcification and breakage of the calcium. And you can see the valve movement before therapy and after therapy on the top, red versus green. And it showed that in these 40 patients, the valve area increased from 0.58 to 0.64. And if you're not done it, natural progression which have gone down to 0.53. Same thing, the mean gradient decreased from 41.9 to 38.8. In 6 months period, these 40 patients did fine, no complication occurred. So it seems to be, particularly patients, there is no treatment. Those cases could be a treatment may be available for this once we refine this technology of the ultrasound therapy. So basically is that the novel non-invasive ultrasound therapy for calcific AS proved to be safe and feasible. And how are we doing?
We're ready.
We're ready. Okay.
Yeah.
Okay. So let's go back to our case the live case now. Tell us where we are and what we have done so far.
Can we focus here for just 1 second?
Yeah.
Is it possible?
Yeah. Show that they're showing it on the top. Yep.
Yeah, so this patient has had a PTFE graft here, which seems
show by the hand a little more.
Very fibrotic and very cicatrized. So we had to go higher up. So external iliac access with the second cut down, because this whole area is so cicatrized and fibrotic. And we did a balloon dilatation.
Now show that angiogram.
Yeah.
Go next.
Yeah, let me do it.
Show me the picture again.
Yeah. Then here, this one.
Yeah. So you can see multiple stent grafts there with the bifurcation stent, followed by balloon dilatation, and then delivery of the E-sheath, and we ballooned the E-sheath.
Did you do shockwave or no?
No shockwave.
Okay.
It's pre-existing stent grafts there.
I see.
Okay, and then we can shoot the aortogram.
So this is the aortogram. You can see the two valves.
But from surgical point of view, challenging. I know it was a challenge.
Yeah, it was very difficult to get access from because the TTFE graft are very frozen on the groin in terms of inflammatory response.
But show this picture. This is very important. You can see the pigtail is coming from behind the first Evolut. So we had to change the position. And
it's
show
still behind.
Yeah.
And then now.
Very interesting. Yes. And right now it is through the main
I'm just going to fast forward it in the interest of time.
Yeah.
But you can see.
No, let it play.
No, here.
Let it play. Yeah. So now you.
So now you go into the lumen.
You only go with the pigtail. Enter only with the pigtail. Then you take your 35 J wire, and with the help of the J wire, you make sure you're in the lumen of the graft. Yeah.
Yeah, so this is critically important because otherwise the SAPIEN-3 will be stuck. You will not be able to track to the annulus.
Again, go back
and that's been described before, that they go outside these transcatheter valve frame through crossing, especially the one with larger cells, and then they are not able to track into the position. So this is extremely important. Usually less of an issue with the Evolut because the diamonds are smaller, but the other valves like Accurate Neo2, Portico, Navitor, Hydra, or other ones, the newcomers with the bigger cells on the outflow have to be very careful where you cross and how you cross.
Now, second is what wire you are going to use now to deliver our SAPIEN Ultra.
Regular Safari.
Regular Safari. Now, what if, knowing that there are so many anatomical valves still projecting without dilatation, what if you try to see just the balloon? You don't want to get stuck with your TAVR valve. Just get a balloon through, it's going easy.
I think with the flex system we should.
No, I know, but should
we may have one chance SS to
no,
get
that's what I'm saying. One chance is that if you want to go through, so why not just get a simple balloon, get a 20mm balloon, a true balloon 2022, just see that there is a path. There's not going to
So
stop.
you're saying you inflate the 20 balloon and track it all the way?
No,
or?
no, I would just say that the projection, remember the first Evolut,
No, we go with this.
the top one, no, just 1 second. We are saying just to do the pathway, just to make sure that it's not getting a prong
Sure.
of the first valve
Flossing,
sticking.
flossing, basically, yeah.
That's it. So just to see, because once you go inside, it will be difficult. Yeah.
It could be different because this has a flex system.
No, I know, but believe me, but
way
those are very small, they are not rigid. Okay.
Try the balloon.
Yeah. Just the pass. I just want to go through the pathways. Because remember, it's still.
So that's a very good point, Dr. Sharma. We've been case reports that actually when they put the SAPIEN, it got jammed up. Because they could not engage. Because remember, the SAPIEN-3 is a naked valve. There's no protector. There's no capsule.
Right.
Unlike the self-expanding valve. So we actually do this quite often in mitral valve in valve cases where we floss with the balloon to make sure we can trap through the prosthetic valve, right? From the septum. That's a very good teaching point, Dr. Sharma bring up to the audience, that if you worry about getting stuck somewhere, a balloon flossing tracking is a good way to test. And because remember also with the SAPIEN-3, you can, once you put the valve in, you cannot take it out.
That's right.
So that's another point of consideration.
This is one. Lower the main.
Because remember, your wire still could go through few of the funnels of
Correct.
the SAPIEN valve, of the Evolut valve.
Yeah, you're basically
You're tracking really nicely as Dr. Sharma's point.
Should we? There's no reason to dilate here.
No, you can balloon just to see because you have a waist, just inflate
do
a
a little
little bit just to see if it gets stuck, right?
Yeah.
Because the balloon doesn't have
I
any
think we'll be
body.
okay. I think you have good trajectory.
But at least we saw the trajectory that we are from the central lumen, and we are ready with the 26 Resilia.
So I guess the trick here is not to push it too much.
Right.
If the valve doesn't flow easily, then ballooning will be a good idea.
No, but I think that what we have seen with this, the trajectory, we have seen it that it should go now. Because remember, the whole question is, we are just seeing our wire going down into the ventricle. Has it gone through some of the strut?
Yeah.
So that was the question.
Yeah, but the balloon has a body, right? That's the
Yeah.
difference. So let me mark out for you guys to get see the bottom because that's very important. And did you inject the rotoglide already?
Yes.
Okay.
There. That's for you, rotoglide.
So,
Keep going.
okay, watch the wire.
Show me all the way up.
I
We are
show
good.
down.
Show me all the way up.
Good.
Careful with the.
Look at how easy it's tracking because what we did, we prepared a vessel. That is the most important part of this case. This patient has gone through a lot in terms of vascular complication. I think we cannot have another vascular complication. So we know vascular complication have very high mortality, and the TVT registry is still in the 2, 3, 4%.
Yeah.
Ours is less than like 0.8%.
Yeah.
So it's very important because we know that's a very high mortality. Okay, 1 second. Let me show you the arch.
The blood pressure is a little soft, as you can see there.
Might be dampened, Dr. Sharma.
So we have only one access, by the way. So flex here.
I have
Max
completely
flex.
flex.
Okay. Then pull the wire slightly.
Not going?
As you center the wire, it should drop down.
No.
Yeah.
Okay,
So
good. Now we are
you saw
going.
the difference, right?
Good.
Yeah.
Now we got.
Okay, let me follow save that, please.
So everything has wire and catheter manipulation.
Okay, let me mark in now. I'm going to go to the angle now. Watch your feet, Sahil. So we're going to go to the implant view. Oh, someone press dual fluoral. Can you, off fluoral, please? Can you put a towel over it? Okay, so so now it's LAO 26. No, I got it. LAO 26, Cordo 8. Good, okay. So this is now pretty good, actually, in terms of parallax. So we take the parallax out off the FX, and we do a core frame alignment view. So we line up the diamonds on the FX to kind of make it easier to.
No pigtail.
No pigtail.
I think we don't need a
Fluoral, please. Let's see. because there's so many diamonds here. Okay, so now this is, you can see, we're now learning more and more with these cases. So when you do what we call frame alignment of the Evolut, you have fewer diamonds to look at, then you can count the number of the nodes, so it makes it easier to actually target your implant.
And today we are going for 5 or 4?
So no, we're going to go for 6 and adjust it down to 5. I think that's the
5,
key.
I thought, yeah.
Because the waist is 23 only,
Yep,
so we have experienced that the dives can be shifted downward.
Okay.
So, Dr. Can you want to show the point?
No, you go with the node, I still go with the aortogram.
Yeah. No, aortogram, go back here.
Go back.
That's the other way to do it as well. So we use both.
So you know 100% you're right. Okay, put it there.
So
That's where it is.
that's our reference aortogram.
So if you go with this,
You have to
right
line
there.
it right here.
Yeah.
So, note 5.
No 6. Yeah, no 6. Sorry, no 6, and then we'll go to no 5.
Okay, go in a little bit.
Yeah, go in a little bit. Yep, that's right.
That's good.
So you can see 1, 2, 3, 4, 5. Yeah, this is 6. Okay. So if you do a dry cine, you'll see it. You can show the audience. It's the dry cine. Okay. So you can do your own counting.
Okay,
1, 2, 3.
180.
Yeah.
Real life.
So no higher. Okay, because we're done in.
Thank you so much. Thank you.
So ready to deploy.
Good, right?
Yeah.
Yeah.
Go up.
Yeah,
Up.
slow, very slow. Oh,
Going up.
All the way. Very
good.
nice.
Yes.
Very good.
Give a breathing room, come back and do one more.
Yeah. Okay. Joe, we're going to post dilate, but
Off,
lungs down.
off.
Lungs down. Okay, not yet. We'll let you know.
Okay. Resuscitate a bit.
Remember, it's the PVL, so
Do you want to give one more CC or die? Or?
we can do one more CC.
Yeah, give one more CC, yeah.
So what we found, and we actually studied this on the bench, is that it's very hard to post-dilate 2 frames, especially the mechanism of PVL. In this case, the valve is working fine, the Evolut, so we don't need to pre-dilate, but we actually even sometimes pre-dilate, especially if it's under-expanded. So this case, we did not need to, but we definitely need to post-dilate to expand the SAPIEN-3. And you can see that here. And
What have you done? You added one more CC?
One more
more
CC,
CC.
yeah.
Okay, lungs down, please. Okay, you guys ready?
Yes, 180.
So we also now stop ventilation to minimize the motion, because you saw there was some motion during the initial deployment.
Very nice.
Good.
All the way.
All the way.
So we're around
Cine.
8 atmospheres here.
8
Good,
now.
Good. No. Okay, good.
Okay, good.
Pacing.
Off.
Off.
Lungs back on, please.
Yeah.
Good, excellent.
So
Okay.
everything looks really good here.
You need a pigtail.
We are
Now,
going to do 2
remove this.
pigtails here. You have big sheath, you can put 2 pigtails. We want to see the real gradient. And then we do the aortogram. 2 things we are going to do.
We're fully deflated, right? AK?
Yes, yes.
Okay.
So the key with paravalvular leak is to make sure the inflow of your second valve is below the annulus.
Get me a picture.
Because otherwise it's not going to seal, because that's the mechanism of paravalvular leak.
Flush.
Usually the first valve was implanted deep. There's not enough radial force. So you don't want to be too deep either. And end up, compromising hemodynamics. But you can see that here. So often the trick is that, before you go on pacing, we would do lungs down, rapid pacing, inflate the SAPIEN to avoid any kind of extra motion, because every nose counts. We have stories from other hospital where the valve went up and then occluded the coronary. Because they wanted in no 4, no 5 with no problem, but they end up in no 6. So this is extremely critical in terms of tips and tricks of how to do this procedure safely. And you can see this here. When you have so many frames, you have to make sure you cross the frame in the true lumen, what we call true lumen
Very important.
of the orifice, and especially like this
How do you want to
situation.
Introduce
We'll put
another
the second.
pigtail.
Give me a wire and a dilator.
So Stam, you want to look at the echo for
That's
us?
fine.
Yeah,
because
waiting,
the femoral
waiting.
pressure was
Yeah, let's have a Stam. Let's look at the
see what
echo
the
while they set up the
gradient
hemodynamics.
We'll be happy to do exam images.
Yeah, please show us a live echo, please, on the main screen.
Yeah.
Okay, give me.
Let's see how the paravalvular look. Look, we haven't
No gradient on hemodynamics, you can
introduce
see that.
Dr. Larakis, our head of non-invasive imaging at Mount Sinai.
So as you can see, nothing.
Show the hemodynamics one side also.
Yeah.
Okay.
Yeah,
Please change the floor screen. Yeah, good, perfect.
yeah,
So
beautiful.
Stam, tell us what you see.
Yeah, trivial. As you can see, trivial PVL.
Wow,
Okay.
wow.
And I did not show the pre. The pre was very eccentric.
Yeah.
To find it, here we move, as you can see, crawl back and forth on the valve.
Yeah. Let's look at the short axis for the audience if they like seeing the short axis. view or explain?
Absolutely, absolutely.
And look at the hemodynamic,
Yeah.
it's fantastic.
And you can see the diastolic pressure came up as
You
well.
can see here, can you put some color, please? Short axis,
Nothing, really.
nothing there.
Nothing.
Let's put the explain, please. Explain. Yeah, nothing, as you can see, minimal to nothing.
Yeah. Good. Okay, can you show us a transgastric view
Yeah.
of the PVL
Yeah,
and the gradient, please?
yeah.
So now we can take
Be
this.
happy.
So you can see
Connect this.
these cases takes a lot of planning.
Okay.
So, and now we have tools and apps available for you to plan these procedures. And obviously, you can work with the companies, manufacturing companies as well. But it's all about the planning execution for these cases. And that's why we think that this is actually a very safe procedure, at least in our experience center, for these cases, versus, let's say, TAVR explant. I think that's one of the interesting comparison is going to be. Of course, we don't know the long-term durability of the second valve. That is the biggest question. So we'll see as we have more of these coming now this year, and last year we're seeing actually more coming to our clinic. They're about 3 to 5 years out, I think. Some of them 7. Actually, we just recently did a SAPIEN XT that was 10 years out. Actually, that's probably one of the oldest 10 SAPIEN XT valve that we found failed. So.
And you say that no gradient there, and the fantastic, this is the case same. They look for, like TAVR is being done in many hospitals now, but for advanced cases, they need to come to the center like this. And that was the guidelines also. When you have complex case, you still should go to the valve centers. And we were the designation from the ECC for the TAVR center. So this patient came to us for that purpose because he had a bad outcome 6 months ago at the other place. And it was tough, challenging. We thought that should we do it, case as a live. I know I had a lot of resistance from our group, but I said, this is the one we want to teach. Everybody is doing otherwise TAVR. And I'm glad that they were able to get a good vascular access. And now, if you advance, you have to advance with the wire.
Yeah, let's get a wire.
But you want to just do it because it looks so good. I don't want to change it.
You have to increase the contrast injection, please.
Yeah, good. Okay, good. Now you're good.
I'm going to go to 163. See if they want me to.
Go ahead, Greg.
Yeah, more volume.
Okay, we are going to do a...
1 second, 12-15. We really do a proper one. So
Yeah, proper aortogram.
it's a big root. So looks good, Stan, from your end?
Yeah, perfect, perfect.
Yeah.
Fantastic.
Wow.
So you
That's the
see,
trace.
so the key, you can see that in aortogram, the inflow of the SAPIEN-3 is just below the annulus.
Yes.
That's how you seal the PVL, right? Because remember, it's not the SAPIEN-3 skirt, it's going to help you. It's the Evolut outside the frame. So you have to have enough radial force against it, and that's why you can see the reduction in PVL. So this is a very important understanding of the mechanism of failure in planning the target implant depth for these patients.
Fantastic.
Yeah. And now you want to pull back to take the pigtail out. No, take the pigtail out on fluoro. No. Remember, you're still in that thing.
Pigtail is already actually
Is out?
Yeah,
Already?
it's
Okay,
out.
good. Okay. So good.
Yeah.
So yeah. So but give. The Pedro, you saw that beautifully orchestrated. This is such a tough case.
PVL.
This is an amazing experience. This is the best. You guys are unbelievable. You want to go with your questions?
Yeah, 1 second, Dr. Moreno. I think Dr. Laracas wants to show the before and after, the PVL, to tell the audience what a difference it makes. So Stan, can you show us that, please? Because it's very important to understand the mechanism of what the PVL jet looks like. I think a lot of people may underestimate PVL. And so Stan is going to show you how to look at PVL. You can show it. Can you show before and after, Stan?
Yeah, after we saw it, but before, just to make a few points, there was normal function, MR here.
This is the baseline.
Yeah, this is the baseline. Appendage was okay. Look at this.
Which one? The second
You
one?
can see two valves together. The valve by itself looks okay. The leaflets open well. And as you can see, this is the X-plane on the leaflets, and they look perfect. As you can see, no PVL here. Minimal PVL to start with.
Yeah.
But look at this. You can miss it actually if you don't do off-plane. Look at this. This is again you miss it, and then off axis, and you bring it in.
Look at that.
So very important, to play with the probe, to turn the probe around in order to be able to bring this this PVL in, and this X-plane. We measure it, and today, in order to find the degree, we do the ratio of the area of the PVL to the area of the valve, and it was 23%, which is moderate as per the guidelines. 10 to 30 is moderate. and this is a deep gastric view.
You're coming?
Again, if you see
We're
again here, if you don't turn the probe, no PVL. So you think that
Beautiful.
everything
Wow.
is perfect.
Fantastic.
Everything is perfect, but you have to turn the probe around. No gradient in the beginning. If you turn the probe around, you bring the PVL in. So very important. And again, the gastric views are the most important views in order to detect the PVL. But the most important is you have to try to find it, because in the regular views you may miss it. You have to go off-axis view to get it.
Yeah, so Stan, show us now. Let's show it live to
Yeah,
show the
let's go
before and
live,
after, because we want to show the audience we actually fixed the PVL.
Yeah, absolutely, absolutely. Again, here,
PVL's
I'll
gone.
show you on this. Can you put some color, please? As you see here, nothing, and it's turn the probe.
Yeah.
As I did before, you remember when I turned it
Yeah.
before, it was coming up.
Yeah,
Now,
yeah.
nothing.
Beautiful.
Now
The
it's
mid-esophageal views, nothing at all.
nothing at all. Fantastic.
Trivial, yeah. And if you go to gastric views,
Now, this is very important for the audience to appreciate, right? Because they say,
this
oh,
is
there's no
important
PVL,
because see
but
again
yeah.
here. Can you put it up, please? Up the color up, please. Yeah. Nothing. No PVL. This is a deep gastric view.
Beautiful.
Nothing. I turn around. Nothing.
Yep.
I turn the other way. Nothing. So
Okay.
very important.
Thank you, Stan.
For the PVL, absolutely, absolutely.
So this is a great opportunity for a few questions. First, when do you actually go ahead and fix the PVL? Always, or you wait for symptoms, or what do you do?
Oh, no, you wait the symptoms, but we learned that the mild PVL, people can live with it, but moderate, they start getting in trouble. And that's this case was. Although last November when they left was mild to moderate, but continues to become more symptomatic. So it depends on how active the patient is. So patient become a little more active, become more symptomatic, and that is how the patient approached us with this complex anatomy. As such, when we sent that e-blast, you saw that valve sitting on each other and going through it. We ourselves were concerned, but you know what? I said, we had to just show it to the audience what exactly happened in this type of cases. I'm so glad that they were able to get the vascular access. I know it was a challenging from their point of view. Another question, Pedro?
Yeah, is there any, we know the PVLs are associated with an increased mortality. That's no question. The issue is fixing the PVLs. Is there any randomized data so far, or is it only anecdotal?
No, but also remember, mild PVL, all the data were in higher risk patients.
Yep.
I think in 2024, if we can anatomically address PVL, we should get down to trace or less.
Yep.
And that's our center. Our center, the mild PVL is well less than 10%. Well less than any published literature. Of course, it's not Corevalve, but we are very vigorous. We have only 2 structural imagers to evaluate all these PVLs. So we know that at least they're consistent.
So mild PVL, so just want to give you the data, national actually is about 9.6 and we are about 6.8. Mild PVL. So that is in single digits. So this is where we are.
Yes.
And all the data have shown that I think the trace is the one what we are aim for.
Yes.
Mild may increase a little mortality with the new valve, but once you get a mild plus, that's where the trouble is. So therefore, every effort should be done in the lab to obviate that. Now, in the past, because of as mentioned, because of high risk elderly at 84, I think the mild PVL will cause less trouble, mild to moderate. But now in a younger patient, that mild even gives you trouble. So key is we go with the trace. In this day and age, what is the optimal tower? It has to be that you are coming out with a trace or none PVL.
Yeah.
And considering the trial that you presented,
Yep.
Dr. Sharma, the first trial, redo TAVR versus de novo, equal outcomes.
At 1 year.
Everybody should be encouraged
Yes.
to fix the PVLs.
Yeah, absolutely. So only question comes is that those were the selected cases. Remember from like 2,000 cases, then they selected about 1,000 because not every patient can get a redo tower. That's the biggest issue.
Yes.
And biggest one most important, actually 2 I would say. One, coronary obstruction, and secondly the patient prosthetic mismatch. Those are the 2 important factors which will let you not to do the redo tower, and that patient will go for surgery.
Fantastic. Do you want to go with
Yeah,
your questions?
I just want to say also,
Dr. Sharma?
I'm going to finish it, and more importantly, we actually at Sinai, we have started now for 1 week TAVI preceptorship, which this is the second time we are done now. We get 5 candidates, 5 junior to mid-level experts from India. we are done last year. Second one is going on now, and all 5 are observing this case in our conference room. So we actually encourage globally anybody wants to come for our TAVI preceptorship of 5 days. We have clear agenda. During that time, we do about 15 to 18 TAVR, 3-4 clips, embolic, ASD closure, all structural cases. So per year, we do about 800 structural cases, but key is that we need to push this field further to make people confident. I know the PCI we have done over the years, training everyone, but now it's about time to train in this structural field also, and we got the great 2-3 people here with Gilbert, Sahil, and Anu that put a time into, so it's not only just doing the procedure. Remember how you get a good interventionist. One, you know the theory, and then you apply that in the practical. So this, the whole purpose of this TAVI preceptorship is not only just show those cases, but more importantly, go to the theoretical aspect of each and everything. Rhythm disorder, hypotension, the valve-in-valve, stroke, all those factors you go in so they become the better operator. So with that note, let's come to here.
Yeah, considering that this is a very, very impressive case, I'd love to hear Dr. Keeney's take-home messages during the procedure.
Good. Anutala.
Now, I think I showed you the most important, probably the point is how to cross. You see that? The use a pigtail to go through those 2 double valves. Like I think Gilbert already mentioned, the diamonds are smaller in this valve compared to the other self-expanding valve, especially Accurate as well as Navitor. The diamonds are larger. Here you have to make sure you saw that with the first we were outside, then you use a pigtail, and with the pigtail, with the J wire, then you make sure you're in the lumen. And I know everybody talks about node, but I'm still go with the angiography. So we went back to angiography, saw exactly where the annulus is on the aogram, and that's how we place the valve. These are the 2 key points that I take home from me when it comes to technical.
Fantastic.
And we can ask now Sahil also that he was involved in this vascular. Our surgical colleagues don't have the microphone. So you want to say how you were able to get your access? No, but verbally that what were the difficult challenges you got without showing the picture? Yeah.
Very tough case. Multiple grafts in the past, prior vascular complications at the time of TAVI. So these cases are in general very challenging in terms of redo access. So one thing we don't discuss about, we talk about redo TAVR and just about the annular anatomy. We should also discuss redo TAVRs in patients who have very challenging access to begin with and how they heal. So we had to do, we asked our vascular surgeons to give us a cut down field. Initially tried the external, the common femoral graft site, but then had to go external iliac graft site. Did a balloon angioplasty of the entire graft segment, followed by E-sheath and then ballooning of the E-sheath. So in general, very challenging case, and went really well. So.
And the vascular complication for the TVT registry is about 4.1%, and Mount Sinai always have been less than 1, 0.7, 0.8, 0.6. Only thing is, which we are not proud of it, we still have to win the CVA, 30-day CVA. At 1 year CVA rates were good. So after the patients are managed well, but the 30-day CVA is still slightly higher than the national average. Okay, let's complete this now. Slides, please. So clearly the selected patients, AS patients in hospital and 1 year clinical outcome of first time TAVR are similar to redo TAVR in terms of hard endpoints of death, MI and other major complications. Long-term data at 5 to 10 years are awaited. TAVR explant continues to be troublesome in form of higher mortality versus redo TAVR, and part of that could be just experience of the surgeon. Hopefully things will get better over time. A small randomized clinical trial comparing self-expanding versus balloon expanding valve in a small aortic surgical prosthetic showed better hemodynamic with a self-expanding valve versus balloon, but there was no difference in clinical outcome between 2 valves at 1 year. Then the newer advances in the balloon expandable valve result in improved valve performance and lower PVL. This possibly can show better long-term durability, and therefore it should be the valve of choice. At Sinai, we use all cases S3 Ultra Resilia. So clearly there is no reason to use any other valve. So this valve is a better valve. Now, of course, in the past, because there was difference in some cost, using in younger, but I would say based on the hemodynamic performance, every case should be done with S3 Ultra Resilia, and that's what Sinai has changed a few months ago. Then TAVR in failed surgical aortic valve with high-risk patients have shown a significant immediate improvement, which is sustained at 5-year follow-up. So it's a good therapy of choice. And lastly, the newer disruptive non-invasive ultrasound therapy, they call it NIUT, has shown promising results up to 6 months in a small series of inoperable severe AS patients, but long-term benefits are awaited. So 3 questions. One is the following statement is not true regarding the outcome of matched redo TAVR versus native TAVR up to 1 year. Similar mortality, similar stroke rate, similar major bleeding, similar residual mean gradient post-procedure, and clearly answer is not true is the similar no. You have a higher residual mean gradient in the redo TAVR compared to the first time native TAVR. Second, following are the true outcomes of 1 year of the Lighten trial comparing balloon expandable with the self-expanding valve in the failed small surgical bioprosthesis, similar mortality, similar stroke rate, similar hemodynamics at 30 days, similar KCCQ score. Clearly answer is C. That is not a similar. Hemodynamics were better with the self-expanding compared to balloon expandable with a lower gradient, better effective orifice, but no difference in the outcome at 1 year. Then the following are true about the 5th generation SAPIEN-3 Ultra compared to the earlier generation S3 and S3U. Lower mean gradient with SAPIEN-3 Ultra, higher EOA with SAPIEN-3 Ultra, better long-term outcome with SAPIEN-3 Ultra, and lower PVL rates with SAPIEN-3 Ultra. And answer here is C. Why? Because we don't have the long-term data. So clearly we cannot say, but yes, hemodynamics are better because this is the first time presented, but it's a great valve. Sometimes it requires a little harder pressure because maybe the thick valve, but with the additional sealing, it's done a tremendous job with a good hemodynamic. With that note, we complete our presentation of this morning, and Pedro, for you to the concluding statements.
Absolutely. Thank you so much for the team in the cath lab, and thank you all for joining us for this very difficult question. Your loyalty is highly appreciated. We will continue showing the most difficult cases to achieve our mission of teaching around the world. Remember, today, this afternoon, all available, ccclivecases.org. Most importantly, we do this the second Tuesday of every other month. So our next one will be May 14 at 9 a.m. Thank you so much.